I know that you mentioned that you also work with ME, CFS. Do you ever have overlap with patients with long COVID or those illnesses? Just because I know that there are a lot of similar symptoms.
Long COVID basically has a very broad definition. The most recent definition was from June of 2024 by the National Academies of Medicine, and it defined it as symptoms that start after SARS-CoV-2 infection and last 3 months. And there is no particular kind of timing of the onset. It's not affected by the severity. Some people with mild or asymptomatic illness can also develop long COVID, but long COVID can also have other co-diagnoses. So it's not exclusive, right? So we have somebody who presents with new symptoms after long COVID, and they may meet diagnostic criteria for ME/CFS. And, this has been debated through the past few years, whether we should diagnose both, whether we should diagnose one. And the National Academy definition made it very clear that if a person meets both diagnoses, that those two should be um, uh, diagnosed to that patient. So you can also have long COVID and POTS, or postural orthostatic tachycardia syndrome. You can have long COVID and seronegative rheumatoid arthritis. So there's you can have combinations. So is ME/CFS the same thing as long COVID? And that's something that's also been talked about. I don't think that we are at a point where we can equate both things. I think that there's a large group of long COVID patients that do meet criteria for ME/CFS. And treating with symptom management that has been used in the past for pre-pandemic ME/CFS patients can be very effective for these patients as well. We don't know if the pathophysiology is the same, and that's going to be told, with research. We're working on using ME/CFS, pre-pandemic ME/CFS, as a kind of compare or a control group to look and compare with those with post-pandemic SARS-CoV-2 onset ME/CFS.
Mhm.
So ME/CFS, by the 2015 definition, requires you to have loss of function and severe fatigue for more than 6 months. You need to have post-exertional malaise, which is also one of the most predominant symptoms in long COVID. Post-exertional malaise is not just feeling tired or, feeling like you can walk up the steps. Post-exertional malaise is an out of proportion onset of symptoms that range from neurological to musculoskeletal that come about with activity that was previously tolerated. So it's not like you're running a marathon and you're feeling bad the next day. This is people that just go to the pharmacy or go shopping, and the next day they can't get out of bed. Their body aches, they have tremors, they may have worsening headaches, they may feel feverish, sore throat, a multitude of potential symptoms, worsening brain fog, really out of proportion to the inciting event. So that's the other requirement. We also need to have brain fog or cognitive impairments or orthostatic intolerance, which is another factor, which means that you can't tolerate upright posture, or being upright triggers symptoms that are relieved by rest. The last one is unrefreshing sleep. So you may be either sleeping, having disturbances in sleep that could present as insomnia, or actually could present as hypersomnia, which means people that sleep more than usual, but ultimately you're not feeling that refreshed after sleep, and the fatigue is not relieved by rest. And
Yeah.
us as physiatrists work with people with impairments. So we are used to treating people after strokes, after traumatic brain injuries, spinal cord injuries that have this level of loss of function. And as a physiatrist that used to take care of these patients before, I see my long COVID patients just the same. These patients have severe impairments that don't allow them to be able to function as they did